In the last session, we had discussed about the certain of the factors about neoplasm. The next is about the carcinogens, that how the cancer is produced. The causes of the cancer, as such, is again a highly controversial issue. As per the historical facts, initially the first of the thing which was noted as a specific cause for the cancer was physical irritation, which is now popularly known as chimney cancer. In the occupation of those who would clean the chimneys, because of the direct contact with the soot, that carbon, the persons, they used to have malignancy or quite frequently, and hence that physical irritation produced due to that chemicals was considered, and probably that is the first carcinogen identified or named as such carcinogen. Then of course lots of factors were considered to be a cause of cancer, and now these days a huge amount of research is going on, and almost every aspect of the life is believed to be some cause of the cancer. Now, because of this confusion, the International Agency for Research on Cancer has made it as a policy that to recognize any entity as a carcinogen, it has to undergo specific criteria, and these criteria are decided by the IARC, and this would accept certain substances as a cancer, and every year, almost every 2 or 3 years once, there would be a report of the carcinogens which are identified based upon the statistical incidents and laboratory research materials, and where there is a very objective evidence. And at present the number is around 116 as per the 2021 edition, and tobacco is the highest or topmost in the list of that carcinogens in as per the IARC report now. So from the present day's point of view, to name any substance as a carcinogen, it has to be accepted by the IARC. The criteria which are mentioned, that laboratory reports, statistical incidents and so on, they have made a specific criteria, and only when then that is considered as a carcinogen. Though in the usual context of the research activities, a huge substances, lots of things like are identified as carcinogen. Interestingly, among the 116 identified carcinogens are named carcinogens in the IARC report, more than 46 are the routine drugs which are prescribed, medicines which are prescribed for the different diseases, including certain antibiotics as well as certain of the so-called essential drugs. Anyway, for all the practical purposes, these carcinogens now are categorized into 3 categories. Physical carcinogens like ultraviolet rays of sun or radiation, or maybe the X-rays and so on. The medical imaging tests also can be categorized as a carcinogen. Chemical carcinogens like asbestos, tobacco, smoke, etc., and a good number of drugs, as I told. Alcohol is also categorized as a carcinogen. Then fungus and contaminated food. Arsenic also, which may be present in the air due to the pollution. Biological carcinogens are the other, such as infections from certain viruses, bacteria and so on. Now, among those carcinogens, as I told you, tobacco is considered to be the most important carcinogen. Earlier, tobacco was considered to be a cause for the cancer of lungs as such, but now it is known that tobacco consumption, either in the form of smoking or consumption in the other way, can produce almost 17 varieties of the cancer, and different organs could be involved, and there is a relationship of that tobacco induced carcinogenesis or production of the cancer could be throughout the body, including or involving almost all systems like urogenital system and the head and neck, of course, locally, as well as gastrointestinal tract system. Lungs, of course, is the major issue. Another widespread carcinogen, or a carcinogen which produces a cancer in almost every organ of the body, is the human papillomavirus infection, HPV virus infection, which is also well known to produce the cancer of cervical cancer of the uterus. But now it is known that it can be a stimulant for the production of the cancer in other organs like ovaries, penis, prostate, gastrointestinal tract, and then lung cancer, head and neck cancer also, or colorectal cancer, breast cancer also is known to be a cause. And interestingly, HPV virus now is tackled with the vaccines. Vaccines against HPV virus has become a regular practice, and one of the cancers which can be managed with the, or which can be prevented with the vaccines as such is the claim about it. As far as the carcinogens and then cancer risk are increased, as per the US statistics, this is about the US statistics, the most important among those 116 causes categorized as such, the different varieties, the most important is the tobacco smoking, then excess of body weight, then physical inactivity, alcohol consumption, ultraviolet rays, poor diet, and pathogenic infections. These are the common varieties of the causes of the cancer as per the statistics presented by USA. Of course, the similar issues are there in other countries also. Maybe slightly this graph pattern may change in other countries. So that's about the known causes of the cancer or carcinogenesis, carcinogens as such. Another aspect of the cancers is about the metastasis, the spread of metastasis. Conventionally, the metastasis is defined as a production of a lesion of the same sort elsewhere beyond the area and beyond the primary area, and we usually name the lesions as primary and the secondary. The mode of spread of the metastasis is maybe either direct or embolic spread. Direct spread is where there is an extension, local extension, as in case of the basal cell carcinoma. The tumor expands, and because the tumor cells, the multiplying tumor cells, they invade the surrounding tissue in the form of some limbs, like the shape of the lesion resembles that of a crab, and hence it's named as cancer. The word cancer comes in because of its similarity to the crab, and cancer word represents crab in Latin language, and hence that word is applied, and it's seen in almost every cancer. It may spread, and as it spreads locally, it usually is initially limited by physiological barriers like fascia, or maybe at times it could be the sheaths of the muscles which can reduce the spread. But once the lesion goes beyond a certain limit, then it can even cross those physiological barriers, reach to the nearby organs. So from one tissue to the other tissue, it may be transferred. Certain of the types of the cancer, like basal cell carcinoma, doesn't cross the physiological barrier. So that's one. Or it could be through the invasion of the lymphatics. The tumors, cancer may spread through the lymphatics in the two forms, either lymphatic invasion or lymphatic embolism. When the lymphatic embolism is, the lymphatic ducts are involved, and gradually it progresses along the lymphatic ducts. Next, it involves a lymph node, and so on. So every time a node is involved in such condition, it's the proximal lymph node which is involved. Whereas there could be an embolic spread in the lymphatics too. That is a few of those fragile circulating tumor cells, CTCs. They may even get into the lymphatics, and they may float through, and they may get filtered in the lymph node, and that could be the secondary. And in such situation, there is no need to have that continuity of the lesion between the tumor and the lymph node as such. So whenever a patient of tumor comes in, and when you examine the lymphatics, it's not only enough if you see the primary lymph nodes or the proximal lymph nodes. You will have to examine the other lymph nodes too to see whether there is any embolic spread or not. Similarly, invasion also can occur through the nerve, along the nerve path, or along the venous path, or along the arterial path, or as I told you, it may be crossing some spaces from one space to the other. That's what we say, the direct spread. Serous spaces among them. The very popular example given is about the Krukenberg's tumor, where a tumor from the stomach, tumor cells from the stomach may be falling into the pelvic cavity as a droplet, and then may produce the tumors in the spread of the tumors in the pelvic organs like the uterus and ovaries, and that's what we call as a Krukenberg's tumor. It could be the other way. A lymphatic spread through the embolus is usually given as the example of Virchow's glands. Virchow's glands where the cervical lymph nodes are involved due to the cancer of the stomach, gastric cancer. The these cancer cells may migrate through the lymphatic vessels, thoracic duct as such, and reach to the cervical lymph node and may produce a secondaries. And it's very important from the clinical point of view. Is a good number of patients may come with only a swelling in the supraclavicular area, but the patient may not have much symptoms related to the gastrointestinal tract, and it could be evidence of the cancer. Similarly, the spread also can occur through the bloodstream from one organ to the other. When the spread occurs through the bloodstream, majority of the conditions, the secondaries tend to occur in the lungs, because lungs is one of the area where the blood gets filtered through a capillary network, and hence whenever there is a spread from the malignancies, the lungs are the major, very common areas where the secondaries tend to occur, particularly in sarcomas, that's the tumors of the connective tissues. Whereas a tumor from the gastrointestinal tract, like abdominal cavity, it can involve the liver, because liver is another area where in the portal circulation the blood gets filtered through a capillary network. So when it spreads through the bloodstream, the secondary sites are quite frequently either in the lungs or in the liver, very frequently, or then of course other organs also could be involved when it spreads through the bloodstream. But chances of a tumor spreading through the bloodstream into the intracranial area, into the brain tissue, is quite lesser. Earlier it was believed that chances of secondaries in the brain would be very little, but now it is known that there could be a chances of these also. The brain also could be involved, that a blood-brain barrier is not 100% foolproof to prevent the cancer spread, but still the incidence is comparatively lesser. Then transcelomic spread is, as I told you, the Krukenberg's tumor, where either it can pass through as a droplet or it can spread along the serous spaces and then produce the tumor in the other organs nearby, near the cavity as such. Similarly, the spread also can occur through the epithelial lined spaces, like from the kidney to the bladder, along the urethra. Now, along the urethra, it may spread down, and these are the types or modes of metastasis. The principles of the metastasis are now is related to the circulating tumor cells or CTCs, and lots of research is going on about the pattern of the circulating tumor cells and their priority now, and whether it's a chance spread or whether there is any biochemical directional issues which make the metastasis in other areas is the important issue. Now, the modes of tumor are spread are a primary tumor invading into the surrounding tissue, a fragile cell moving through the lymphatics, reaching to the lymph node, and from one lymph node to the circulation in the form of circulating tumor cells, then reaching to the other area. Now, this initially was believed to be due to the pattern or some accidental pattern, but lots of research is going on, and now they know that they have come to a conclusion, like there is some biochemical preference or maybe molecular factor, including the genetics, which produces this specific location of the secondaries. So, identification of these genetic characters of the primary can help in identifying the metastasis. Of course, this is also applied in the area of identification of the secondaries, as well as to a certain extent prevention of the secondaries too. The researches going on are summarized here, year by year, starting from a century ago. The latest is about application of barcoding strategy to determine the metastatic potential. So, once you have a tumor pathology, the metastatic potential can be identified. Among the very recent investigations, that microRNA is considered to be one of the important factors which decide about that. In case of the biological characters or sensitivity of the tumor cell related to the site of the secondary also now is established very specifically with the breast cancer. A breast cancer which is having that HER2 type of immunochemistry. The immunochemistry, of course, we will be discussing a bit of this immunochemistry in relation to breast CA later on when we go into the specific chapters later on. Now, there we will discuss like what is HER2 and HER negative and so on, or ER positive and so on. Now, suppose a tumor is having a subtype of HER2, chances of secondaries in the bone are more. If the tumor is having ER positive as well as HER2 positive antigens, then the chances of secondaries in the liver are more. And breast cancer having HER2 enriched and then TN non-basal variety, then chances of tumors in the brain is more, secondaries in the brain are more. Or the tumor having the non-basal luminal HER2 plus P59, the chances of secondaries in the lungs are more. Or lymph node involvement is in the luminal type and so on. So this kind of identification is now possible with the molecular features also, which is a very advanced study. And by this, once you have identified the primary, the possible site of the secondary can be predicted. That's the important issue, and that's one of the important issue. The next part is about the tumor biomarkers. To make the diagnosis of a tumor, as I told you earlier, the investigations were limited to the imaging studies, clinical examination, imaging studies, and in all that, the diagnosis is always quite delayed, because by the time a tumor is identified, even by the small, highly sophisticated PET scan, the divisions would be a few thousands of the divisions would have occurred. And moreover, the chances of missing the diagnosis also are more. And hence, there is a trend to identify the tumors or diagnose the tumors based upon some biochemical substances present in the body, and these are considered as the tumor biomarkers, and these are defined as substances that can indicate the presence of cancer or certain benign conditions in the body, and they can be used for diagnosing the cancer. They also are useful in planning the treatment, predict the prognosis, and it also, tumor markers also could be used for the response, assessing the treatment response, like a tumor marker which was high in the beginning. After the treatment, if it gets reduced, that means the tumor is responding as such, or it also can assess the aggressiveness of the cancer. So, biomarkers or tumor markers are one of the recently developed areas in the treatment of cancer. Earlier, the markers were very few, but now the markers are almost have become a regular aspect of the clinical practice, oncological practice, and the markers are categorized as susceptibility markers, or which can predict the risk of the possibility of tumor. Of course, a bit more of the detail of these issues we will be discussing when we discuss the individual tumors in the coming sessions, like the diagnostic biomarkers or biomarkers which can predict the prognosis, biomarkers which can help in monitoring or which can have a prediction about the possible course of these, and pharmacodynamic response biomarkers, like markers which can help in identifying the response to the treatment, and safety biomarkers. Biomarkers could be of different sources, like the biomarkers could be produced from molecular hybridization, it could be the DNA sequencing, it could be polymerase chain reaction, or it could be immunohistochemistry, or it could be liquid biopsy, or it could be electron fluoroscopy, and that whole area of the biomarkers and the technologies used for the biomarkers is a very advanced issue, complicated issue, and this has to be tumor specific. And among the most popular biomarkers now is the microRNAs of the variety, and the 2024 Nobel Award, which was awarded just 2 weeks back for American molecular biologists Gary Rokan and Victor Ambrose, was about the microRNA researches on microRNA and the potential of microRNA in predicting or in suggesting about the cancer biomarkers in the use of identification of the tumor, as well as the microRNA is being used for modifying the behavior of the cells, and possibility of a treatment for the cancer by modifying this was the research subject for which the Nobel Award was given. And just 2 weeks back this award was announced, and probably you might have seen this photograph in any of the newspapers of this. So the important is or summarizing this is the area of cancer biomarkers is a very rapidly developing area, and lots of complex chemical substances and chemical processes are involved, and to follow up this would be quite difficult otherwise. So you need to have a very specialized approach. At present, the two biomarkers which are identified are many, and specific biomarkers for different organs, different types of the tumors are now used as such. So this list is exhaustive, and I think it will be quite difficult to follow otherwise. So there are certain techniques. I will come to that part of the issue, like how to memorize these types of the biomarker and to get the help. Of course, all these biomarker identification is not a subject of routine investigations. You need to have the specific investigations as such. Now, for the confirmation of a diagnosis of a cancer, there are certain hallmarks, and that hallmarks are now categorized as 10 hallmarks are defined as the type of the definition of the tumor now latest, and they are categorized as 10 hallmarks, which is also having a formula of 6 plus 2 plus 2, and these characters have to be identified in the cells by any of these technology, and these characters are hallmarks of the cancer are cellular process of self-sufficiency in growth signals. That's where these growth signals escape the normal controlling growth or dependent growth, they become independent. Insensitivity to the growth inhibitor signals, that growth inhibitor signals like the age factors or the contact inhibition, that is escaped or avoiding that, and evading the programmed cell death, that apoptosis being evaded. Then limitless replication potential, sustained angiogenesis, continuous production of the blood flow into the tissues, invasion. These are the 6 established hallmarks as such. Then 2 additional, which were added very recently, are immune invasion, the involvement of the immunological system, a stress response phenotype where the metabolic substances like acidosis or there could be mitotic activity or chromosome instability or reactive oxygen species like oxidative stress in the tissue. Tissues would be unhealthy, having the evidences of the stress responses. Stromal subversion, where the structure of the stroma is altered, or a cytokine response also is now added to the hallmarks of the tumor. So the whole definition of the tumor has been modified now, and it has come to the level where you have 10 hallmarks. Among them 6 are very established. The other 2 plus 2, they are the provisional, they are just added recently. So all that is important is to confirm the tumor, that a pathology is of a tumor. Now it's not only the histopathology, you will have to go to the other aspects also, like the microcellular function, the genetic functions have to be studied. The tumor markers which are quite popular even now in the routine laboratories, which can be used which are often used, like alpha fetoprotein for a diagnosis of the liver cancer, which is also it is also used for monitoring the treatment and stage the cancer. Cancer antigen 125 is used to monitor ovarian cancer treatment and recurrence. Then CA15/3 and cancer antigen CA27-29 are used to monitor breast cancer treatment, and beta-2 microglobulin is to monitor treatment for multiple myeloma. CEA as such would be used for the embryonic antigen like cancer of the intestines, colonic cancers. PSA is quite frequently used for diagnose the prostate cancer. Cytokeratins, these are commonly used for evidence of the tumor progression and recurrence. The markers have a limitation in the sense these markers are not very specific. Some tumor markers are produced both in normal as well as cancer cells, like PSA. PSA higher level doesn't confirm tumor, but it increases the possibility of a tumor. Having possibility of a false positive is high, or having BRCA's these genes in a person doesn't confirm that the person has a breast cancer, but it increases the risk of having the breast cancer as such. So that person would have this increased risk as such. Moreover, the tumors do not have a sensitivity. Like, it's not necessary that all those conditions of tumors would have a marker positive, or every marker positive patient may not have a tumor. There could be a lot of variability from person to person about the tumor markers, and hence a standard reference range is quite wide. We will have certain examples later on when we go into the specifics there. Then analytical variability, because the laboratory techniques are very complex, chances of having that errors in the analytical process by the laboratory would also be a possible issue. The diagnostic utility of a tumor is very limited because it's not very specific, and all cancers do not have a tumor marker. There could be many cancers still where the tumor markers are not known, and it may be even fluctuate. The tumor marker levels can fluctuate due to many factors as such, and may not reach until the cancer affects it. So there is a trend to identify some specific test which can diagnose a tumor of any organ of the body. See, with the tumor markers which are used now, you have to select the right tumor for a right type of the malignancy. So the whole process of diagnosis becomes difficult. So initially you have to guess about the possibility of a tumor in that person, and then select the right tumor marker and see whether that tumor marker is having suggestibility or not. So the whole issue becomes complex because you will have to select the person with the high risk acid. So the attempts are now to identify or have a test which can identify almost every sort of the tumor. This kind of attempt is going on, and as per the latest issue, of course this Gallery test still may not be available in India, but it's now claimed that Gallery test, cancer blood test, one of the blood tests, one single blood test can identify as many as 50 different types of cancer, and this test has got a FDA approval very recently, some a few months back. This has been studied, and it could be like it's considered to be very having very high specificity. The specificity is considered to be like only one among the 200 people tested may have a false positive result. Otherwise, this Gallery test could be one of the simple tests, one single test to identify different sites of malignancies, and probably in due course of time such tests will come into the practice, and then the diagnosis of tumor could be easy. Then another aspect of the tumor cancer is the screening, to identify the person before the cancer has developed and be watchful, identify like when the tumor has developed. So that cancer screening has become a cult now, and WHO has given a guide for cancer screening, like who have to be screened and what are the methods of screening. The whole process of the screening is now identifying the patients who have or persons who are eligible for screening, then having some specific methods, landmarks for identifying these areas, then the real testing to be done, and once the diagnosis has to be done, like whether the tumor is there or not. This helps in early diagnosis. So whole approach of this screening is towards early diagnosis, and it's claimed that early diagnosis can help in the cure of the tumor. So there is a bit of controversial issue. The screening is large number of population has to be screened, and there could be one or two who may have symptomatic disease, and so there could be some persons who might have been identified quite early. But this approach of screening now and that culture of the screening itself has created certain problems in the present society, that the major issues are overdiagnosis and overtreatment. The patients, there could be, like suppose there is a genetic susceptibility, you identify that, name that person as a having like BRCA's genes with the breast cancer. This has occurred now. BRCA's genes, if they are positive, then the person is tagged as a possible risk of cancer, and almost 70% of the persons who have that BRCA genes might not have developed cancer breast throughout the life, but once you have tagged them, there could be psychological issues, or there could be a possibility of a over-treatment, like a mastectomy being done unnecessarily, and it is already done. There is a huge statistical issues. There could be a false positive or false negative test also with this screening. Psychological effect of the screening could be quite harmful. But in advanced countries, in the developed countries, the rigid screening protocols are followed, like the regular follow-up as such. And with the screening also there is a limitation like as I told you, the examination of a lesion by simple hand examination. Like suppose for the breast cancer, the protocol is self-examination, then of course mammography, and then if necessary MRI, CT and PET. As per the data, a breast examination by hand, the tumor which can be identified could be, or having the least size of the tumor which can be identified could be 1.5 to 2 centimeters. Less than that may not be palpable, may not be seen. Mammography can detect a tumor as small as a pencil eraser, small one, and MRI can detect as small as 1 centimeter, and CT can detect about 3 millimeter size. PET scan can be diagnosed about 0.2 milliliters or about 2 millimeters in diameter. But by the time the PET scan has identified a tumor, it would undergo many divisions. The divisions which occur in the tumor cell are considered to be by the Gompertzian statistical analysis. So in the initial stage, the number of divisions are lesser. The divisions increase rapidly at one stage, and then they become identifiable. So the cancer becomes curable if you have identified the tumor at this stage. But this stage often fails to identify. At this stage, it may not be possible to identify the tumor by most of these screening protocols. So the target of the screening is to identify the patients at this stage, so that the cancer can be cured. But most of these investigations or all that screening protocols may fail to identify the person at this stage, and it may reach to the level where the tumor has already reached to a rapid growth level, and then of course the next course of the tumor would be quite rapid. Now early screening and detection by screening is, as I told you, is has become a standard protocol in advanced countries, developed countries, for quite a long time, and the prognosis of the breast cancer has not changed much. See, this statistics is by a huge study and published in November 22. You have the source here, it's not mine. Breast cancer diagnosed in women, and the screening control program was started in 1923 to 32. Where from that onwards, the statistical incidence of the tumor and the outcome of the tumor, like fatal complications of the tumor, has not changed, rather it is continuously increasing. So screening has not produced much effect as such. Similarly, in India also, of course, though the screening practice has not been established as a rigid technique as such, or rigid criteria, There are no specific guidelines about having that screening as mandatory. The issue is the breast cancer tumor pathology hasn't changed much in the recent years as such. The incidence has become more. Then there is another view on the screening issue also. My purpose of referring to this issue is not to confuse you or not to undermine the importance of the screening, but the other aspect of the screening also is to be known as such. Now this is based upon a publication. Again, this is not my data. The data from a publication of 2020, where the screening cancer is from early stages to advanced stages, and particularly limited to cancer of the lungs as such. And a large number of people are involved in this study. The number of persons who are examined are quite huge, and the conclusion of the data is important. Is suppose the patient is hypothetically the patient has a cancer which may be at certain stage. With the early stage diagnosis and screening, you might have named that, identified the patient as cancer at one stage. But if the patient is not screened and all the technologies of tumor markers and high technologies are not involved, you wait till the patient presents the clinical symptoms of tumor. It could be right late. So at this stage, the patient may not have a clinical symptoms of tumor, but because of this high technology involvement and that screening protocols, you might have identified the patient, and the average, it could be like, if you have identified the age of 60, the total expected life would be around 70, and we claim that because the patient has survived for more than 5 years, survival period of the tumor is considered to be more than 5 years. Whereas in a patient who is diagnosed at the age of 67 because of a delay in the diagnostic process, still the expected life period is the same, 70, but 5-year survival period will be 0. Now whether this screening has really produced some advantage or not is the issue of controversy. If you have diagnosed the patient at an early stage by all that complex treatment of the tumor, as well as the tagging the patient as a tumor person, the psychological impact, patient would survive with all that for the same period. Whereas if there is a delay in the diagnosis, patient might have lived and enjoyed the life without having that tag of tumor for this much of the period, and he had that tag of the tumor and all that complex treatment issue only that much. But statistically, the claim is that the survival period, 5-year survival period, which is considered to be the benchmark for cancer cure, is lesser in that delay in the diagnosis, whereas 5-year survival period is quite high in the with the screening techniques. So whether the screening techniques have really produced some impact or not is the issue of controversy. The other view, of course, one view is that screening technology and early diagnosis has really helped, but the other view is the screening technology might have named that, tagged a patient as cancer at early stage, and the patient is living with the cancer for a longer period, or identified cancer with a longer period, or known to be a cancer patient for a longer period. But if there is a delay and you wait till the patient has developed the symptom of cancer, the duration of the person living with the cancer may be shorter, but the total expected life period will be the same. Now similarly, another of the data with the lung cancer screening, another of the data from again a huge source, it represents almost the same issue, the diagnosis at an earlier period and the survival period later. So such data are coming up now, and the survival rate, now we use certain specific terms in the diagnosis or in the treatment of cancer, and these terms are a bit confusing. Overall, there is a survival rate, overall survival rate, and cancer specific survival rate, 5-year relative survival rate. These are certain of the defined terms. Survival rate is the percentage of people who are alive at certain time after the diagnosis, as I told you that earlier. Whereas overall survival rate is irrespective of the diagnosis of the tumor, how many of the people have their expected life period, reached their expected life period. So when these complex terms are used, the real utility of the cancer treatment and the cancer diagnosis protocol is becoming somewhat controversial, like whether early diagnosis is really and screening is going to help or not is the issue. But still, when I say this, I am not against the screening protocols. I am not saying that it's useless, but these issues have to be considered with a pinch of salt, and the real utility has to be considered by assessing the other aspects of the social life as such. So, cancer specific survival rate is the total survival period after the diagnosis of cancer and death due to the other causes as such. 5-year survival rate is considered to be the benchmark for the cure as such. Now, lots of articles are coming up about this screening and very little. Those who are interested, they may go through these articles. I have just given a reference of a few of the articles which are published in the recent years, like 2011, 2012, and so on. So, many of these give the other aspect. The popular aspect is screening would be beneficial, but the other aspects, the issues related to the limited utility of the screening and the early diagnosis are published as such. So, those who are interested, they may go through that. Now, the next aspect is about the staging of cancers. The cancer staging is the important measure to make the diagnosis or to assess the severity of the cancer. The oldest of the popular technique is TNM staging, and that the TNM staging was initially initiated for the breast cancer. But now the staging protocol has to be followed for individual cancers in a different manner. Of course, we will be discussing these issues when we discuss some of the common varieties of the tumors in the coming sessions, and that staging protocols for that particular cancer also will be discussed there. But the most popular is TNM, where the T word represents tumor, N represents node, and the M represents the metastasis. Now, initially it was only by the clinical examination. The TNM was by the clinical examination. But now the TNM classification also has to be by clinical staging, that's also named as CTNM, or pathological staging based upon the histopathological investigations. There is some method of categorization, it's also called as PTNM, and post-therapy or post-adjuvant staging, like during therapy, the staging has to be assessed, and that's the YCTNM or adjuvant therapy. During the adjuvant therapy, that's adjuvant, we will come to that, like where combination of more than one protocol is used, or adjuvant drugs, neoadjuvant drugs are used. Then recurrence of or retreatment, like if the patient has recurrence, then that the assessment of TNM protocol is RTNM. Autopsy TNM is when a person is dead with the cancer, and in the dead body the staging of cancer is done. So the current protocol of TNM is not as simple as the usual textbooks would say, like depending upon the size of the tumor, you say T0, T1, T2, and so on. But the issues are complex because for this classification is for each of the tumors specific. Moreover, depending upon the clinical, pathological, or the therapeutic aspects, the discipline has been changed. Even for the breast cancer, the original TNM was having T0 to T4. Now, the current clinical staging of the breast cancer based upon TNM, the issue is TX is where the tumor cannot be assessed by clinical parameters, but the patient might have the evidence of the tumor otherwise. T0, no evidence of a primary tumor. TA is papillary non-invasive tumor. TIS is carcinoma in situ. T1 is invasion of subepithelial connective tissue or which has extended beyond the lamina. T2 is invasion of muscular layer. T3 is invasion of renal parenchyma or peripelvic issue, and T4 is invasion of adjacent organs as such. Or similarly, lymph nodes. NX, as the regional lymph nodes, cannot be assessed. N0 is negative nodes. N1 is single node of less than 2 cm. N2 is single node between 2 to 5 centimeters, and N3 is multiple nodes. Metastasis M0, M1, and TX and T0 are no evidence of the tumor. Then that's about the clinical staging. For the breast as such, There is a radiological rating also. That radiological rating is by RATS technique, or that's breast imaging report and data system. By RATS is a breast imaging and reporting data system is there. And there again you have that by RATS category 1, 2, 3, 4 and 5 to 6. The when you have sent a patient for ultrasonography or maybe MRI scan, you get the report in terms of by RATS 1, 2, 3, and this again gives you a probability. If there is a possibility of, or if there is a report saying that it's a by RATS 3, it's probably benign and the malignancy probability is less than 2%. Whereas by RATS 4, there is a strong suspicion of malignancy and the possibility is a 2 to 94% probability of malignancy. By RATS 5 is highly suggestive of malignancy, where the probability is more than 95%. By RATS 6 is known biopsy proven malignancy and it has to follow the different procedures. So when we send a patient for MRI scan or ultrasonography scan, usually you get the reports in the form of that by RATS number. So all that you have to know for the present would be predicting the possibility of risk asset, and if it's a by RATS 4 or above, the follow-up is necessary as such. So that's one of the issue. Another of the issue is about the cancer of unknown primary. With all the technologies, including the tumor markers and sophisticated technology, the incidence of a tumor patient of cancer having the secondaries, but the primary being unknown, identification the primary will become difficult. Such incidences are increasing rapidly, and it's the data from USA where you have the maximum sophisticated technology and the screening program. In all such conditions, even in such conditions, the diagnosis of a cancer of unknown primary is something like around 32,590 patients were diagnosed in 2023 based upon the data. I have given the data from the American Cancer Society as such. So that number is quite huge. Now consider the issue in a less developed country like India, where you do not have that kind of rigid protocols of screening and identification. Possibility of having the patients of unknown primaries are quite huge, and we do get such cases quite frequently, and this is one of the basic problems. And the death rate, even in USA, death rate for this unidentified primary is considered to be like quite huge, 26,130 males and 20,000 in 2023. So with all the advanced technology, there is always a issue of failure of that. Then the last part of our general oncological principle would be the treatment options. Treatment options for the cancer could be either surgery, chemotherapy, radiation, targeted therapy, immunotherapy, stem cell or bone marrow transplant, and hormone therapy. These are the options of the treatment. The most reliable and oldest part of the treatment is surgery, which is oncosurgery. The basic discipline of oncosurgery is that a tumor has to be removed completely if possible. Otherwise, it could be either radical excision with the edge clearance, where the normal tissue is removed along with the tumor if possible, or it could be a debulking option where the size of the tumor could be reduced so that the harmful effects of the tumor cells over the body could be reduced, or there could be combination schedules which are now becoming popular. Combination schedules are where the tumor size could be reduced by radiation or chemotherapy in the initial stages, and once it is size and vascularity and the size is reduced by chemotherapy, then the surgery is done. So oncosurgery would involve any of these options. A palliative surgery is where you may not be possible to cure the tumor or handle the tumor, but to prolong the life of the patient, like in a patient of cancer esophagus, put a gastrostomy tube so that the patient is fed with the gastrostomy tube, his general condition would improve. Then another controversial is a preventive surgery. Like if there is a high risk patient, even before the tumor is identified, the organ is removed, like removal of the breast in BRCA genes patients, or removal of the uterus, hysterectomy done after the age of 40, and so on, the highly controversial issue. So these are the different principles of the oncosurgery. Then comes the chemotherapy. Chemotherapy is the word chemotherapy means making use of a chemical for the treatment of tumor, and the initially Paul Ehrlich in 1900 used this word, and the types of the chemotherapeutic, of course chemotherapy is a chemical substance, it could be used for any disease treatment, but now chemotherapy word is almost limited to the treatment of cancer as well as certain of the antibiotics where the organisms are damaged. Now chemotherapeutic drugs used in cancer treatment would have the complexity. All of or majority of these chemotherapeutic drugs would be affecting the growth of the cells, which have to be targeted to the malignant cells. The cancer cells should be damaged, but healthy cells should not be damaged. That is the basic issue. So the goal of the treatment would be cancer cells should be destroyed and the healthy cells should not be destroyed. And hence the type of the tumor, these chemotherapy drugs which are now used are either tumor antibiotics, alkylating agents, or platinum reagents as such, or they may be the antimetabolites which may affect the metabolic activity of the tissues, or it could be like those who may affect the genetic constitution of the tissues as such. And again, I will not go into the details of this. The common and these chemotherapeutic drugs used are categorized as antimetabolites, alkylating agents, or these topoisomerase inhibitors which can affect the genetic multiplication, or anti-tumor antibiotics as such. Corticosteroids also can be used in the treatment, nitrosurias or mitotic inhibitors, plus there are certain other chemotherapeutic drugs, herbal origin and so on. Now, we will not go into the detail of these, like when to use and so on, but at least when we go into the individual tumors, we will be referring to certain of the issues. There is a significant development. Historically, there is a lot of development in the chemotherapy. A successful chemotherapy of the tumor started in 1935 with the nitrogen mustard in the lymphoma. Till then, there was no successful issue, but now it is claimed that with the different developments, the newer developments like monoclonal antibodies or target specific substances like tyrosine kinase which are invented recently. That's about, in brief, about the chemotherapy. I will not go beyond that. Radiotherapy is exposing high intensity rays to the tumor. Again, it could be of mainly three categories. EBRT, where the organ, the tumor itself is exposed to the radiation directly, where the machine which is kept outside the body, and the issue is radiation is toxic to the nerve cells, toxic to the cells as such. Intensity of the radiation and focusing of the radiation should be to the organ, that malignant lesion, and it should not affect the surrounding tissue. That is a total issue, and that's why you will have to have lots of technologies. Newer technologies are there in the EBRT variety, where the specific instruments are used which can focus on the area. Again, I will not go into the detail. Or it could be brachytherapy, where the radioactive substances are kept inside the body, or systemic radiotherapy, where the radioactive substance is injected into the body and then it will reach to the surface, like radioactive iodine in case of thyroid gland pathology. Thyroid gland pathology, when you give radioactive iodine, it reaches to the thyroid because of the biochemical activity. Then comes the targeted therapy. Targeted therapy is the drugs which are having a specific target over the molecules of cancer cells. They are not cytotoxic, but they affect the specific areas of the malignant cells, either the chromosomes or maybe the genes or specific aspect of the genes which could be advanced, and which is now becoming quite popular. This targeted therapy is now becoming quite popular, and lots of numerous development are coming up. The research articles are also quite huge there, and the common types of target therapy are mainly the seraptogens or neoadjuvant drugs as such, and they are now becoming popular. Very popular is Herceptin. Herceptin is one of the popular targeted drug which is used. Again, we will not go into the detail of it. Another aspect is immunotherapy, where the vaccines are used to either prevention, Now, preventive vaccines, HB virus, human papillomavirus, and these vaccines now are becoming very popular. And in India also now we have a national program of HB vaccination and HBs antigen to prevent the cancer, which has now become almost established. Therapeutic vaccine for bladder cancer, BCG vaccine are being tried, but still they are not in a regular issue. Then the adjuvant therapy is where there could be a combination of different modalities like radiation and chemotherapy and so on, which are planned. Then neoadjuvant therapy, adjunct therapy, where one is given after the other, post-remission therapy, these are the other techniques as such. Newer techniques which are coming up are palliative care, precision or personalized medicine, where this has become now a quite popular issue, where every character of the tumor cell is identified, and based upon that a personalized medicine is prescribed, and hence that becomes an issue of the oncological practice now. Then off-label drug use, biosimilar drugs, where the drugs may have a similar molecular property, but they could be synthesized in a different manner. Off-label drug use is the FDA approval could be of something different, but the physician may suggest this for some other tumor conditions as well. Tumor agnostic drugs are the very newer investment and the testing guide to the treatment. Now, because the whole issue has become quite complex, the issue of selecting the right drug, now lots of guides are available and guidelines are available. The most popular guideline for the tumor is you can, and this you can see register in a website. Medscape website provides this hematology and oncology decision point guideline, clinical guidance, where if you type the type of the tumor and its subtype, the recommendation for the investigations, which of the tumor markers are to be used, you will get that information. And even once you have done that, you may even get the right selection of the combination of the drugs, like which sort of the treatment has to be given, whether it has to be adjuvant therapy, neoadjuvant therapy, and the survival rate and so on. So individual details of each cancer can be had at your fingertips. The decision point is one of that. Of course, there are many such sites. One site which I generally use is the decision point, which is comparatively easy. So once you have a detail of a cancer patient, then you can predict the prognosis. You can predict about the possible course of the treatment in the current issue, which helps in suggesting like whether the patient has to go to the contemporary treatment or whether the patient can manage it in our setup or so on. So I generally use that criteria to advise the patients in many issues, because the development is very complex. To follow up every development is not so easy. We may have to make use of these decision points. So decision point and guideline is one of the current developments in the cancer treatment protocols. The most common type incidence of cancer is increasing rapidly, and the type of cancer is having certain pattern in the geographical distribution. In India, the most common type of cancer in India for males is mainly about the tobacco-induced cancer, oral cancer, whereas in the females it's breast cancer, which is the most common type. Statistics of cancer at a glance throughout the globe. Number of cancer is increasing rapidly throughout the globe. Compared to that, the number of new cancer cases in India is lesser. Then age standardized incidence rate in India is lesser than the global average. The global average of age standardized rate is 196.8, whereas this for both sexes, whereas it is 98 in India. And the risk of developing cancer before the age of 75 years is around 10 in India, whereas globally it is 20. The reason, of course, whether it is really the lesser incidence of cancer or otherwise is the other issue. The issue is the fatality rate, the death rate in India due to other these communicable disorders is higher, whereas the non-communicable disorder like cancer, before the cancer developed, the person would die due to other issues, whereas in the advanced countries, the non-communicable disorders have become more and communicable disorders are prevented better. So that's about the logic issue. But anyway, by the comparison, the incidence of the cancer in India is comparatively lesser. Of course, elsewhere in the Western countries, or if the global average, lung cancer are the most common. Breast and colorectal becomes next. In India, breast cancer is most common. Oral cavity, lip oral cavity is next. Cervix, uterus is next. But number of mortality rate in India also is lesser, and risk of dying from a cancer before the age of 75 years in India is around 7.2, whereas it is around 9.6 in the other global average. So comparatively, maybe from the statistical point of view, India is in a better position in case of cancer as such. Now, the latest in the development of the cancer treatment is a cancer reversion. Whether the cancer cell can be reversed or not, still at present there is no standardized protocol for reversion of cancer, but maybe in future lots of research is going on, and in future we may have a situation where the cancer process can be reversed. With this we will conclude this today's session about general oncological issues. In the next session we will discuss about specific cancer types, and the first would be about breast cancer. With that we will conclude today, and if there are any questions, like there are no questions, so we will wind up.